All right, so let's take a look at the lungs. Right lung, left lung. If we zoom in here on this coronal cut or frontal cut, frontal view of the rib cage, we see that the lung tissue here is surrounded by two membranes. There's an innermost membrane called the visceral pleura, and there's an outermost membrane called the parietal pleura. And in between the two, there's the pleural cavity. Now the pleural cavity is a potential space that it contains a lubricating fluid that allows those two membranes to glide against each other. And if those two membranes, or one of those two membranes gets irritated, you then have pleuritis, which then increases the amount of friction between those two membranes, and you develop pleuritic chest pain, a burning sensation in your chest. Now it's important to note that the innermost membrane directly touches and surrounds each lung. The outermost membrane, the parietal pleura, is connected to the chest wall, okay? So let's take a look at this diagram here and see what happens when you take a breath in. So when you take a breath in, it's 21% oxygen, and that oxygen makes its way into your bronchial tree, down your trachea, your right and left bronchi, bronchioles, okay? And you end up with a lot of oxygen here inside the lung tissue, inside the alveolar space, right? So here we have the innermost membrane, the visceral pleura, outermost membrane, parietal pleura. In between the two is that potential space that we call the pleural cavity, and here we have the chest wall. Well, let's say we have an issue and we have a tear in the innermost lining, the visceral pleura, right here. So let's say we have a hole here. Well, every time you take a breath now, it's like a deflating balloon. The air, 21% oxygen, that's inside your right lung here is then going to escape out that hole and start to fill up this potential space. Well, the potential space then gets a little crowded and it ends up crushing a lung. And that's what we call a collapsed lung or a pneumothorax. Pneumo means air, thorax means chest cavity, okay? Let's take a look at a normal chest x-ray here. We can see anything in here that's dark is very thin and not very dense. Anything in here that's light is dense and thick. So for instance, your bones are dense. We can see your bones fairly easily. We can see your diaphragm, intestines. Dark, dark, because your lungs consist of mostly air. Yes, there are blood vessels, and yes, there's tissue there, obviously, but overall, it's fairly dark with some patchy whiteness here. That whiteness is other tissues, blood within the lung, because remember, your alveoli are surrounded by pulmonary capillaries, the smallest blood vessels in the body. So there is blood in your lungs, okay? Now, in this case, we have a collapsed lung here. So the right lung is collapsed and is becoming crushing. So all that air, all that oxygen that normally would come down into the lungs and fill up the lungs like this one here has escaped out a hole. Let's say the hole is here, okay? So now you've got all that oxygen is going in between the visceral pleura and parietal pleura and slowly crushing this right lung. We call this a tension pneumothorax because pneumo is air, thorax is chest, and in this case a tension pneumothorax is when you're crushing a lung and you can actually crush the heart. And when you crush the heart with air, because remember, blood needs to stay within your blood vessels, otherwise it's useless. Air needs to stay within your lungs, otherwise it's useless. So when this air has escaped and is crushing the right lung, crushing the heart, cardiac output decreases, meaning the heart can't really pump effectively. So that means the patient's blood pressure is dropping. This patient is going to be complaining of shortness of breath, probably chest pain. They're going to look pale because they've dropped the right lung. The right lung has collapsed, so they're not getting good oxygenation in. They're not getting rid of CO2, so they're going to look pale, chest pain, shortness of breath, pulse ox is going to be low. If we can get a blood pressure on them, their blood pressure is probably going to be low, okay? So the treatment for this emergently is to relieve this pressure. Well, how do we relieve this pressure? We have to actually punch a hole in the outermost membrane, the parietal pleura, to let this trapped air escape, okay? But before we do that, we have to really make note that underneath every single rib, can we see that on the camera? No, we can't. Underneath every rib, there's a costal artery. Okay, and there's a vein. Okay, so when we punch a hole in the parietal pleura, the outermost membrane, we have to make sure that we don't punch through that costal artery or costal vein. So here's what we use. Say 3.5 inch 14 gauge needle, 3.25 inch rather, needle, and there's a sharp hollow needle surrounded by a flexible Teflon catheter. We know it's a 14 gauge needle because it's color coded orange. So what we do is we count down. We feel the sternum, and we feel the ribs, and we feel rib number 1. Oh, there's a clavicle. Rib number 1, rib number 2, rib number 3. We go in the second intercostal space or third intercostal space, mid-clavicular. Okay, so rib 1, rib 2. That's the first intercostal space. Let's go right here, a second intercostal space. So we're going to feel right there. That's where we want to go. Mid-clavicular, so right in the middle of the clavicle. And we're going to take the needle and we're going to put it along the superior aspect of the inferior rib. So we're going to ride it along the top portion of the bottommost rib. And you're going to insert the needle all the way through. All the way through, you're going to bury the needle. And once the hub is flush with the skin, needle goes out, goes in a sharps container. This stays inside the patient's chest, and you may or may not hear a rush of air, or if there's blood within the chest, blood coming out. So this is a temporary solution. The definitive solution is to get this patient to the operating room, but in between doing a needle thoracotomy and the operating room, in the emergency department, they're probably going to put in a chest tube. And a chest tube is going to be a bigger tube to allow more air to escape, because if we can get a big tube in here to allow all this air to escape, this right lung will have an easier time reinflating. Okay? That's how we treat chest tube patients. And lastly, you always want to put these patients on oxygen because they're going to be hypoxic because their oxygen level is low. Okay? That's it.